Hello, and welcome to the DiversityRx Your Voice webinar series. My name is Julia Puebla-Fortier, and I'm the project director for the DiversityRx Your Voice project, and we're very happy to have you here today. I'd like to thank the California Endowment for providing the funding for the Your Voice project, and also acknowledge my colleagues Candace Matthew-Healy and Ann Turner, who are also on the call with us today helping out on the technical side of things. So I just want to orient you a little bit to who we are if you're new to DiversityRx. We're a nonprofit organization that has provided policy development, research, education, and support for healthcare providers and others who are working to improve healthcare for minority, immigrant, and indigenous communities. We have a number of projects that we run, including a website and a listserv, and we're also the co-producer of a national conference series. And, of course, we are also running the Your Voice project this year. So just to review for you today's agenda, the webinar is going to go from 1 o'clock to 2:15 Eastern Standard Time. Typically, our webinars are 60 minutes, but we find that when we get a lot of questions that people often would like to continue, and so we will give you the option at 2 o'clock of gracefully signing off if you'd like, and those of you who'd like to continue can do so, and we'll try to do some more Q&A. We're going to start off with Mara Youdelman, and she's going to talk about the first set of items related to healthcare reform, and then she's going to be followed by Sarah Lichtman Spector, who is going to focus particularly on some of the immigration-related issues that have been coming up in this discussion. And then we're going to have Q&A, as I mentioned, for up to 25 minutes if you stay on for the full call, and then we'll just close out the webinar. Now, just to tell you a little bit more about how we do Q&A on our webinars. You, as the audience, are muted at all times, and that's because we have several hundred people who are on the webinar, and it doesn't work so well from the perspective of sound quality if everybody is live. And so what we ask you to do is to use the questions window at the bottom of your control panel to submit your questions in writing. And if you'd like, when you're doing that, you can indicate which speaker you want the question to go to, or we can make that decision ourselves. And you can submit your questions at any time during the webinars, during the presentations, the first one or the second one, or afterwards, even when the Q&A has gotten going. We will see all the questions. And because there are a lot of people on the webinar and we can't possibly get to all the questions in this short period of time, we will pick some questions for the presenters to answer, but we will be keeping all the questions that you've sent to us. And then after the webinar is over, we will ask our speakers to answer some additional questions, and those will be sent to you by email and also posted onto our website, where you will also find copies of the presentation slides and a resource document. So let me just point you out what it looks like for the question pane. You'll notice that you have a control panel, which usually lives on the right side of your screen. And so where it says questions log, you will see that there may be questions. That's where you can type in your question. And then, as I said, we'll forward the questions to the presenters and try to get to as many as possible. Now, just a little hint about the control panel. For many first-time participants in a GoToWebinar, the control panel has a habit of disappearing from view, and what you end up with is just a little tiny sliver on the right-hand side that doesn't have all the controls that you might want to use. We recommend that you click on the View option at the very top of the control panel, and where it says Auto Hide the Control Panel, please make sure that's not clicked, not checked, and then your control panel will stay on your screen throughout the webinar. So with that, what I'd like to do then is move on to our presenters, and I'd like to introduce them to you first. Mara Youdelman has worked at the National Health Law Program since August 2000 on issues including Medicaid, language access, racial and ethnic disparities, and data collection. She's the director of the National Language Access Advocacy Project, which is also funded by the California Endowment, and is designed to increase awareness of language access issues at the federal level. Mara also coordinates a national coalition to develop a consensus-driven agenda to improve policies and funding for individuals with limited English proficiency. So as I said, Mara's going to lead us off, and then she's going to turn the mic over to Sarah Lichtman Spector, and I'll just introduce her right now, too. She is also a staff attorney at the National Health Law Program. She joined NHELP in March of 2008, and she works on language access and immigrant inclusion in healthcare, among other issue areas. Before she joined NHELP, she worked at the Legal Aid Society of D.C., focusing on access to healthcare issues, particularly with respect to language access services, Medicaid, and Medicare. She graduated with a BA from Brandeis University and a JD from Georgetown University. Mara, why don't you go ahead and get started?
Great. Well, thank you very much, and welcome to everyone. We really are thrilled to have the opportunity to be talking to all of you today. I'll be pulling up my slides in just a second here, and then I can get started. And as Julia said, I'll be providing an overview of health reform issues and walking you through some of the provisions that are in the various bills. Sorry, my computer has decided to be pokey today, so it doesn't want to let me show anything. So let's see. Okay. See, we thought we would have issues with my computer today. You know what, Anne? If I can ask you, because my computer just seems to have frozen, to ask you to run the slides for me, and I'll tell you when to move on to the next slide. And Anne, you can tell me when that first slide is up.
Sure, Mara. I'll have that up for you in just a moment.
Okay. Why don't I talk a little bit, I'll give you a little bit of a background of the National Health Law Program, which is the organization that both Sarah and I work for. The National Health Law Program, and this will be the second slide you see after my title slide, is a national, nonprofit, public interest law organization, and our mission is to improve healthcare access and quality for low-income individuals. As Julia said in her introduction, we coordinate the National Language Access Advocacy Project, which is funded by the California Endowment. And part of that project is convening a stakeholder or coalition of groups at the national level. And we've been working for the past 6 years on improving language access policies, resources, and funding from the federal level so that the policies at the state and local level can also be improved. In terms of an agenda for healthcare disparities, and Anne, I'm on the third slide right now, there's been a working group of organizations that's been coordinated by the American Psychological Association, and there's over 200 organizations, coalitions, and groups that have been meeting together with the agenda of ensuring that health disparities are addressed in health reform. And we've put together a number of sign-on letters from these broad organizations and coalitions, and we've also put together a resource page that is hosted by the National Health Law Program on our website that provides a lot of information about the working group and also from its members. And so we've provided a clearinghouse of principles and position papers, and if you go to the website www.healthlaw.org, you can click on the icon from our homepage for the Working Group on Health Disparities and Health Reform and get a lot more information about many of the issues that we'll be touching on today. Next slide. What I want to do quickly is give you an overview of the process, where we are and where we're headed. As most of you probably know, health reform has been under discussion in both the House and the Senate for months at this point. There were 5 total committees that have jurisdiction over health reform. 2 of them in the Senate Finance Committee and the Senate Health, Education, Labor, and Pensions, or HELP Committee, and then 3 committees in the House, the Ways and Means Committee, the Energy and Commerce Committee, and the Education and Labor Committee. All 5 committees, as of yesterday, have now finished their work on health reform. So the next steps is that the bills have to be merged. So the 3 committees in the House have to merge 3 different bills into one bill that the House will consider in debate on the House floor. the Senate has to merge two bills from the Finance Committee and the Health Committee and come up with one bill that will be debated on the Senate floor. It's very likely that the Senate is going to want to get 60 votes in favor of a bill. There are some procedural issues where it might only take 50 votes. I'm not going to get into all those details, but given the interest in getting a bipartisan bill from the Senate, it's likely that 60 votes is going to be needed, which sets a higher threshold for getting votes on amendments and getting votes on the final bill. After the Senate and House have both finished their own bills, then there will be what's called a conference committee. And the conference committee has the responsibility for working out the differences between the House bill and the Senate bill. In the past, we've seen some historical deference given to the Senate bill. We don't know what's going to happen this year. That remains to be seen. But in large part, if there is a bipartisan vote in the Senate, and so far there's at least one Republican in the Senate Finance Committee who has voted for the bill, there might be more leaning towards provisions that are in the Senate than in the House. Once the conference committee decides on the compromise or the collaborative bill, then it goes back to the House and the Senate, who each have to vote on it again before it goes to the President for signature. One other thing of note is that a lot of what I'll talk to you is addressing broad concepts in these bills, and there's not often a lot of details or specifics as to how these provisions would be implemented. So even once health reform is completed this year, there will be a lot of work in the administrative agencies, and particularly the Department of Health and Human Services, which will be tasked with issuing the policies and the regulations to implement the health reform bills. Next slide, please. So any information that we provide is current only as of today, in large part because this is still very much, as you all know, a work in progress. As I said, the Senate Finance Committee actually voted yesterday on its bill. So we have not yet seen the merged bill from the three committees in the House, and the Senate is just getting started on merging the bills between their two committees. So again, it's subject to change as we move both to the floor for floor debate and then during the debate. And the best way to keep up on this is to monitor the bills and monitor the home pages of the Senate and the House committees that are addressing this, because they post updates to their legislation on a regular basis. Next slide. What I want to do is provide you both an overview of some of the issues that I'll discuss today and also the general topics I'll discuss today. So in terms of the broad topics, I'll be walking you through Medicaid, CHIP, and Medicare, the three major public health or publicly financed health programs. We'll talk a little bit about the exchange, which is the, or it's called the gateway in the Senate Health Committee bill, but the exchange is where folks who are uninsured and don't get insurance through their employers or through Medicaid, CHIP, or Medicare will be able to go and look for insurance and possibly get some subsidies. We'll talk a bit about prevention and wellness and a bit about workforce. And next slide, please. In terms of the issues that we're going to cover today, we're going to talk in the frame of culturally and linguistically appropriate services, or CLAS. We'll talk a lot about data collection, and then when I turn it over to Sarah, she'll be talking us through a lot of the issues related to coverage of immigrants. So let's get started on the substance. Next slide, please. In terms of prevention and wellness, there's certainly been a lot of talk about the need to have resources and funding to address issues of prevention and wellness. It's not enough to give people health insurance, but we also need to be providing resources so that folks are making the right health decisions and healthy behaviors that will hopefully prevent diseases from ever happening in the future. In terms of the Senate Health Committee, there are a number of references to the need to provide culturally and linguistically appropriate services and specifically to target racial and ethnic subpopulations. And they talk about these issues in terms of programs related to pain care, to oral health, and to funding for community transformation grants. The Health Committee was the main Senate committee that has jurisdiction over prevention and wellness. Next slide, please. In terms of the House, they also have addressed prevention and wellness issues. They specifically initiate a new center, a Center for Quality Improvement, that would be disseminating best practices that are done in formats and languages that people can understand. So you would expect that materials would be provided in culturally sensitive ways and translated into multiple languages. The House also has a health IT, or information technology, provision. Folks may be familiar with some of the health IT provisions that were included in the stimulus program that was enacted earlier this year. That law required that health IT and health information technology systems, or electronic health records, have standardized fields to collect race, ethnicity, gender, and language. The House bill and the health reform bill goes beyond those 4 issues and broadens it to collecting and developing standards for sexual orientation, gender identity, disability, socioeconomic status, and rural, urban, or geographic setting. So this would create standardized fields and standardized categories for how information should be recorded in electronic health records. Now, of course, the process towards moving to electronic health records is going to take years, but it is very important to build these standards in today at the ground level, because it's much harder once these systems are in place to often implement significant changes. Next slide, please. I'm now going to switch over to workforce issues, and you all know the importance of having a diverse workforce to be able to care for diverse populations. Again, the Senate Help Committee has a number of references related to culturally linguistically appropriate services and racial and ethnic populations. They mention this a number of times in regards to funding that will help train healthcare providers. And so there's references in training for primary care providers, for dentists, for behavioral health and mental health, and for community health workers. The House also addresses these issues in terms of workforce, and specifically says that there will be funding for cultural and linguistic competency training for healthcare professionals. And in separate funding that's provided for a pipeline to nursing program, the House legislation specifies that funding can be provided for English as a second language, or ESL classes, so that folks would gain the English skills so that they could then participate in the grants to train in the pipeline for nursing. Next slide, please. As important for many of the populations that folks on this call care about, it's very important that healthcare be provided in a non-discriminatory manner. And so there's been a lot of efforts from folks to try to get a provision explicitly requiring non-discrimination in the activities and policies that are funded by the health reform proposal. So the House does include a broad non-discrimination provision that would address both public health and healthcare and related services, and specify that the services must be provided without regard to factors that do not relate to the provision of high-quality healthcare. It's a very expansive provision, and is one that many groups are supporting, and we're hoping to see that that gets added into the Senate bill as well as the process moves forward. I'm going to go to the next slide, please. Another issue of concern to many groups who are working on health disparities and health reform is the Office of Minority Health. As you know, the Office of Minority Health is housed within the Department of Health and Human Services and undertakes a lot of activities with relation to health disparities and culturally linguistically appropriate services. They were the ones who issued the CLAS standards. And for a number of years, the Office of Minority Health has been without official reauthorization in federal law. So it still exists and it is still funded, but it really is essential that it gets formal reauthorization and formal authority that has lapsed since 2002 or 2003. Right now, neither the House nor the Senate has any language in any of those 5 versions of the bills that would reauthorize the Office of Minority Health, although Senator Cardin in the Senate is proposing an amendment that would reauthorize the Office of Minority Health. And so we look forward to getting the text of that amendment and monitoring that as the process moves forward. Next slide, please. At this point, I'm going to switch over to some specific issues with relationship to both language access and data collection. The language access work has been coordinated mostly by the coalition that I mentioned and Julia mentioned at the beginning of this work at the webinar. For over 6 years, there's been a coalition of healthcare provider associations, advocacy organizations, interpreter associations, and language companies and accrediting organizations who've been working together to advance policies related to language access at the federal level. And that work has been graciously funded by the California Endowment. That coalition came up with a number of priorities for health reform. And as the process has moved forward, they've sort of boiled down to 3 primary asks that we're seeking to have included in health reform. The first is there was a provision enacted earlier this year as part of the Children's Health Insurance Program Reauthorization Act, or CHIPRA, that increased or enhanced the federal payments for language services for everyone in children's health insurance programs and for kids in Medicaid. And this would give states at least 75% of the costs to pay for language services in CHIP and parts of Medicaid. It's a good provision, and we're very excited about it because we really hope that it will encourage more states to help providers by paying for interpreters. But unfortunately, it was not extended to all of Medicaid. And so one of our asks in health reform is to have this provision extended to the adults in Medicaid rather just to the children in Medicaid to whom it applies right now. A second issue is with regards to Medicare. Right now, Medicare does not pay or reimburse for interpreters or translated materials for any Medicare enrollee or Medicare provider. And what we would like to see happen in health reform is for there to be a 1-year study by the Centers for Medicare and Medicaid Services to examine the best ways that Medicare could pay for language services. And then there would be a 3-year demonstration program to look at the implementation of those study recommendations. And this would be able to start the process and gather the necessary data so that down the road there would be additional information as Medicare decides whether or not to actually pay for language services. The third issue is looking at a requirement that any of the plans, the health plans or insurers who participate in the exchange, and again, the exchange is where people who are uninsured will be able to purchase health insurance, but that any plans participating in the exchange should be providing culturally and linguistically appropriate services. And what I'll do now that you sort of know the broad concepts of what we've been looking for, is I'll walk you through where things are in the House and the Senate. So next slide, please. In the Senate Finance Committee bill that was passed yesterday, there were no provisions included on Medicare or Medicaid or the health plans in the exchange. In the Senate Health Committee, there was a requirement to provide culturally and linguistically appropriate services and plans in the exchange, which they call the gateway. But there were no provisions related to Medicare, Medicaid, or CHIP, but in large part this is because the Senate Health Committee does not actually have jurisdiction over those programs. The jurisdiction falls to the Senate Finance Committee. So where we stand right now is the possibility when the Finance Committee and Health Committees merge their bills that there would be inclusion of a provision regarding plans in the exchange, but as of now there would be no funding or provisions related to Medicare, Medicaid, and CHIP. Next slide, please. Things are more positive on the House. The House does include all 3 of those original asks, so the Medicare study and demo, that enhanced match being extended to adults in Medicaid, and requirement for plans in the exchange to provide culturally and linguistically appropriate services. In addition, the House has included a few other provisions. So first is the House would provide grants to hospitals to help reduce readmissions. And the hospitals would be able to use that money to pay for language services, both for interpreters and for translation of materials, in hopes that being able to effectively communicate with limited English proficient patients could reduce hospital readmissions if these patients better understood their discharge plans, their follow-up care, and their courses of treatment. Next slide, please. The House also provides some specific information regarding the exchange. And so it requires the plans or the insurers to provide culturally and linguistically appropriate communications and services. There's a separate requirement requiring the use of plain language. And in the definition of plain language, it says that plans must include consideration of limited English proficiency individuals. And then further, in the administration of the plan, in terms of outreach and enrollment to individuals who would be participating in the exchange, information, again, must be provided in plain language and in culturally and linguistically appropriate methods. So now I'm going to switch over to data collection. Next slide, please. And again, there are a lot of reasons why data collection is important to the issues related to disparities in culturally and linguistically appropriate services. In large part, as you know, if there is no data, it is very difficult to identify and address health disparities and also to do any planning for language services for individuals who are limited English proficient. So again, there's a number of groups who have been working on a variety of data collection issues. And here are some of the basic requests that have been put in on data collection. The first is to require that all of Department of Health and Human Services programs, activities, and surveys would collect race, ethnicity, and language data, and also collect it by sufficient subpopulations for disaggregation. And this gets to the point that if you just collect data on the broad Asian and Pacific Islander categories, you might not be able to get enough data to disaggregate by Vietnamese versus Chinese versus Korean. And so it's important in the provision that there be sufficient collection on subpopulations. The second request is to require the collection of race, ethnicity, and language in Medicare. Right now, Medicare doesn't collect this data, so it's very, very difficult to analyze any Medicare patient populations to identify disparities. Another request is for Medicaid to use the Standard Office of Management and Budget, or OMB standards, so that you actually could compare and contrast Medicaid data with other public health programs. And then the last one is to require CHIP, the Children's Health Insurance Program, to collect language data. Right now, there is no requirement to do so, and again, therefore, it's very difficult for states and healthcare providers to do any planning in advance to help CHIP enrollees who might need language services. Next slide. So now I'll take you through what's actually in the bills, and this will be my last topic, and then I'll be turning it over to Sarah, who will be talking about coverage of immigrants in these bills. So in the Senate, that Health Committee bill does include a broad data collection provision that would address all HHS programs, activities, and surveys. And it actually goes beyond race, ethnicity, gender, and language to include geographic location, socioeconomic status, disability, and it also addresses subgroups. In the Senate Finance Committee, an earlier paper that was published by the Senate Finance Committee did specify that the Senate Finance Committee was considering improving data collection through Medicaid, Medicare, and CHIP. But unfortunately, the bill that was passed out of committee yesterday does not include these provisions. In the House, next slide, please, we do see some similar improvements on data collection. First, there's actually the creation of an Assistant Secretary for Health Information Technology. We talked a little bit about the health IT earlier, but the House bill would require standards for the collection of a variety of data elements that are important to identifying and addressing healthcare disparities. And you can see the list in this slide. So at this point, I'm going to turn it over to Sarah. And just as a reminder, what Sarah is going to be talking about primarily is the coverage of immigrants in the health reform bills. And then we're very happy to be able to take over, leave lots of time for questions and answers, and have more of a discussion with you. So at this point, I'm going to wait for Sarah to pull up her slides. And again, thank you all very much for participating. One thing I will say, Sarah will give on her last slide some contact information for us so that if you do have questions that don't get addressed today, you should feel free to send us an email, and we'll also provide you with an email for the National Health Law Program. So if you'd like to stay up to date on activities that NHELP is participating in, we'd encourage you to sign up for our mailing list. So at this point, I will hand it over to Sarah.
Hi to all of you. This is Sarah Lichtman Spector at the National Health Law Program, and I just want to begin by thanking Julia and the folks at DiversityRx for having us and giving us this opportunity, and all of you for participating and attending today. As Mara and Julia have mentioned, my charge today is to talk about immigrants and their inclusion or lack thereof, depending on the bill, in each of the three pieces of legislation that we're talking about here, the HELP, the Senate bill, the Senate Finance bill, and then the House bill. I am sure that many of you, if not all of you, have heard much about immigrants and their status vis-a-vis health reform in the last 2.5 to 3 months, as it's become one of the hot-button issues to be talked about. I want to take a step back and talk to you about where we come from with respect to this issue with the National Health Law Program. We believe strongly that there is a human right to health, and that you can read and see more about sort of how that plays out in all the components of health reform on our website. We have principles about what we think need to be included throughout healthcare reform. With respect to how that plays with immigrants, one of the components of a human right to health is that there needs to be universal coverage or coverage for everyone. And when we say everyone, we actually mean everyone. And that means irregardless of various factors like immigrant status. And it means that we're looking for equitable treatment of immigrants. If immigrants pay taxes and pay into the system, I think it is the fair and equitable thing that they should be able to receive and obtain coverage. So with that said, in looking to how does equitable treatment play out, we've really been looking at three main policy goals to achieve that equity, and I'm going to run through those quickly and then jump into how the bills have addressed those issues or not, as the case may be, in just a moment. So the first is to remove current restrictions that are imposed on legal immigrants in the public health programs in Medicaid, CHIP, and Medicare. I'm sure many of you know that in 1996 welfare overhaul, there were enormous amount of restrictions placed on on legal immigrants, and they did two main things that are important to know. One is that those restrictions narrowed the group of legal immigrants who are eligible for Medicaid, CHIP, and Medicare, and it imposed a 5-year waiting period that we talk about colloquially as the 5-year bar, so that most commonly if legal permanent residents or green card holders have that status and might be eligible, they still have to wait 5 years after they've gotten that green card prior to being able to be eligible for Medicaid, CHIP, and Medicare. So the first thing is really to see if we can remove those restrictions on legal immigrants and get them eligible for these programs that are critical. The second is focusing on affordability, like we've all been focusing on affordability for everybody in the country, vis-a-vis immigrants, really looking at how to protect lowest income immigrants so that the health coverage they're able to obtain is actually affordable for them. And that leads us to two specific things, looking at the subsidies that are going to be offered and whether or not immigrants are eligible for those subsidies in the exchange, or gateway, as Mara described, as this newly created entity that's going to provide private insurance for the individual market and the small group market, and then leads you back to the public programs, at least Medicaid and CHIP, that are available for lowest income folks here. The third goal is to really think about whether or not the bills are protecting immigrant families. So we all know that most immigrants are here are living in families with children, and that most of those families have at least one citizen or legal child. And so really looking at how and whether those children are protected and the families are covered as a unit. So with that said, I'll jump right in. The first is the Senate Help Bill, and it does allow legal immigrants to get insurance through the gateway, as they call it, instead of the exchange, the private market, as well as subsidies. They have not lifted the 5-year bar in Medicaid, CHIP, and Medicare, and as Mara mentioned, they have no jurisdiction to do so, so there was no surprise there, but there was no mention of it. There is a specific provision that undocumented persons are prohibited from receiving subsidies, and each of the three bills do that. And the Senate bill, Help Bill, does nothing with respect to mixed households or family coverage. It is focused on the individual and sort of doesn't do one thing one way or another with that respect. Turning to the Senate Finance Bill, there's a prohibition in the Senate Finance Bill on undocumented immigrants from purchasing into the exchange, even if they would want to pay in full, so not just with respect to the subsidies, which is in the other two bills, but also were they to want to purchase with their money into the private exchange, they're prohibited from doing that. They do allow legal immigrants to get coverage in the exchange and to be eligible for the subsidy credits, And while Senate Finance is the committee that does have jurisdiction over Medicaid, CHIP, and Medicare, the committee did not take action to lift the 5-year bar, the current restriction in those public programs. With respect to mixed households, there is a specific provision that was added in, specifically protecting citizen or legal children, both that they could obtain child-only coverage in the exchange, as well as directing the secretary or the commissioner that will be created of this new exchange to make sure that subsidies can get directly to these children where there aren't parents for any number of reasons available to be applying for them. But there are two problems. The first is that there's going to be an affordability problem, and the current bill in Senate Finance, as drafted, has drafted eligibility rules that are going to really hurt families and likely prevent many of these kids from obtaining the affordable coverage, the subsidies that might be available. And the second is that, as we all know, that there's lots of research that shows where families aren't covered as a unit, where adults aren't covered, that 6-year-olds don't take themselves to the doctor. So if it is that you've set up a system where you're protecting kids and you're covering kids, but you're not making health insurance available to their parents and their family members, it's going to have a negative impact on those kids being able to both get coverage and get treatment. That's what a lot of research has showed. So that will be another barrier, even if the provisions are there that make the kids actually eligible. In the House bill, similar to the other two bills, legal immigrants can purchase insurance in the exchange and they can get subsidies. There's also a clear prohibition that undocumented persons cannot get subsidies. That's in the context of the exchange. And there, too, there's no lifting of the 5-year bar, albeit there were one of the 3 committees that did have jurisdiction that action has not been taken. So at this point, I just want to turn us back to, Mara gave a really nice outline of where are we going from here, and just reiterate both the House and on the House side and the Senate side, the bills need to go to the floor. There are the potential for amendments on both sides, and things still to change. After that, the 2 bills need to be reconciled and will likely go to conference committee, although it's possible that one House could adopt the other chamber's bill. In total, we're expecting to see a conference committee to reconcile the 2 bills prior to assumably a bill going to the President's desk. So the last slide, I wanted to make sure that you all have our information. It has both Mara's email as well as mine. And as Mara mentioned, a way to get on our mailing list to get the kinds of information we send out. People should feel free to be in touch on that email as well for other kinds of questions. So with that, I think I want to turn it back to Julia and the other folks at DiversityRx, and I think we're going to go into some Q&A.
Great. Thank you so much, Sarah. That was a terrific presentation, and thank you, Mara, too. A lot of information in there and a lot of very interesting provisions that both the House and the Senate can be considering. And so let's move to the questions. And I'd like to start by asking Mara this question. I think one of the first ones that we got was, is there funding included in either of the bills to assist clinics in the transition to electronic records? I've heard from clinics that serve Native communities that they're very concerned about the high costs that will be involved in making the switch to these new electronic records.
That's a really good question, and the cost of switching to electronic health records can be high depending on the nature of the practice and where providers are at this point. I'm not familiar with provisions in the current health reform bill, mainly because health IT is not an issue that we have been as closely following as some of the others. However, in the stimulus bill that was enacted earlier this year, which had it's called the High Tech Act included in it, there was specific funding included to assist Medicaid and Medicare providers in making the switch and giving them some funding to help subsidize the costs. So I don't know if there was additional funding specifically for community health centers or other clinics or those affiliated with the Indian Health Service. But there may be, and that's something I'm happy to do a little bit more sleuthing in if you'd like to send me an email directly.
Okay, and as a follow-up to that question, one of the other issues that was brought up was as we roll out training regarding demographic data collection to mirror federal, racial, and ethnic categories, are there legal considerations that we should keep in mind as we collect this information?
Well, I think there are a couple of considerations. One is whenever you're collecting data, race, ethnicity data, language data, or other data, as we've been talking about today, on disability, on gender, sexual orientation, sexual identity, LGBT status, et cetera, that there needs to be both a sensitivity to the request, making the request, training for the staff who are making the requests, and then the legal considerations is keeping that information secure and confidential and private. And that comes into play both under HIPAA, the Health Insurance Portability and Accountability Act, which does set up very explicit requirements for keeping personal health information confidential. But also there might be requirements in other laws. And I think it's just important as we go down the path of collecting demographic data and data on various subpopulations that there is a specific focus to the reasons why we're asking for this data and that information is explained to patients, as well as a strong commitment to keep this information confidential and that the uses are not going to be to impact direct patient care, but to be used for analysis and identification of data disparities and trends.
Okay, moving on to a different topic. We have a participant here who says, although theoretically all organizations, private physician offices, hospitals, etc., who receive federal assistance of any kind must provide interpreter services for their patients, I was recently told that offices that receive only Medicare Part B do not have to comply with the federal law. Could you please verify this and explain why?
This regards the application of Title VI of the Civil Rights Act, and there is an exception that has been written into policy that was actually written very soon after Title VI was enacted back in the 60s that did exempt Medicare Part B providers from compliance with Title VI. I do want to clarify 2 points. One is it is only Medicare Part B providers, so it's not Part A, Part C, or Part D, or other providers who receive federal funding. The second limitation is that if a provider does receive both Medicare Part B funding and some other federal funding, that provider is subject to Title VI for all of his or her patients and not just those that receive federal funding. The exception is a long-standing one, and it's based on the interpretation of the literal language of Title VI. I would argue, however, that if you're looking at issues in terms of quality of care and patient-centered care, that there really is no reason to rely on federal law to provide language services. Now, I'm a lawyer, so of course we like to use the law and point to the law, but I think really as we're talking about health reform and we're talking about the need to ensure that everyone has access to high-quality health care, that the need for language services is embedded in effective communication, cultural competency, and patient-centered care. And so while there is a basis in law, I think there's certainly greater recognition that even beyond the law, there's very, very strong reasons to provide language services.
Thank you, Mara. Okay, we also have a question regarding the Office of Minority Health. As you had mentioned in your presentation, the Office of Minority Health has not been reauthorized, and someone's asking what the current status of the Office of Minority Health is and what their current function is.
Got it. Well, this is sort of the fun aspects of Congress, that even if a program is or an office is authorized for a specific number of years, very often the authorizing legislation can expire, but the program or the office continues, which is the case of the Office of Minority Health. So even though the fact that it's authorizing legislation expired either in 2002 or 2003, it does continue to exist. It is still a very robust office, and it is continued to be funded by the federal government. The distinction and the need to have the reauthorization is to actually have the law in place so that it is not a year-by-year funding issue, but rather that it can be reauthorized for a set period of time, and then the funding and both the organization's policies and structures will remain in place without subject to being changed on a year-by-year basis. So it gives the office consistency, an ability to do more long-term planning, and it also gives an ability to really focus on what the needs are for the Office of Minority Health, and so that the definitions and the policies and procedures and authorizing legislation can be put in place to guarantee the stability and efficacy of the Office of Minority Health in the long term.
Thank you. There's also a question regarding community health workers. Given the recent attention to the potential of community health workers, promotorists, to effectively address disparities, what provisions survive that will encourage integration of CHWs into the system? And what is the potential to get such provisions added? Are they tied to proposals for enhanced match at all?
Well, again, whether something will ultimately survive is, I'd love to have that crystal ball. It really is still very much a moving target and literally does change day by day, and that's why we had that caveat at the beginning of saying what we're telling you is current today. By the end of the day, the House could release its merged bill from its 3 committees, and things could have shifted. So with that caveat again, where we have seen mention of community health workers is in the Senate Health Bill, and that there is some funding for training grants for healthcare providers, and one of those training grants is for community health workers. I don't recall seeing it in the House. I don't want to swear to that. I'll see if I can look through some other information and just confirm that. But again, whether it remains in is going to depend on a number of factors, including the merging of the HELP and the Senate bill. If it doesn't get in the merged bill, whether someone offers an amendment on the Senate floor, and then where things fall out when the Senate and the House start to negotiate and merge their 2 bills together. So I completely agree, and it's a program and an idea that the National Health Law Program very actively supports, and it certainly has gotten mention in health reform, but unable to predict where things will fall out in the end.
Okay. Another question. Is there anything? Go on.
No, I'm sorry. I just want to clarify about the enhanced match. The enhanced match that I was talking about was very specific to Medicaid and CHIP, the Children's Health Insurance Program, with regard to payments for language services. So if community health workers were accepted by the state as someone who could provide interpretation services, the state might be able to get the enhanced match, but it would depend really based on state by state and who the state designates are eligible to receive reimbursements as interpreters or to translate.
Thank you. Is there anything addressing the conflict between states and the federal government on who to pay for interpretation services and extending coverage through Medicaid and S-CHIP to immigrants? For example, requiring states to extend coverage to legal immigrants and not applying the 5-year ban, the 5-year bar.
There's no current bill that has the lifting of the 5-year bar through the Medicaid, CHIP, or Medicare programs, and we're still hoping that there will be amendments offered both in the House bill and on the Senate floor to do so. But one of the things we've certainly talked about, and we've gotten a lot of support from the states and the local governments and the counties and the hospitals, is about the burden that not providing Medicaid and CHIP and Medicare coverage to those folks lands on those states that decide to pick up those costs and provide that coverage, either through state replacement programs or local county programs, or that the hospitals and the clinics themselves pick it up. So that's something that we're actively working on, and if folks want to talk about that, they should feel free to, and engage on that, should feel free to be in touch with me more about that, but the bills don't currently make those changes yet.
Candace, I was unsure if the first part of that question was related to language services before the discussion of the coverage of immigrants.
Yes, it was talking about interpretation services and extending coverage through Medicaid and S-CHIP.
Oh. Right. No, it had both issues in it. So in terms of the payments by the federal government to states to pay for interpreters and translations in Medicaid and CHIP, it still remains a state option to do that. So the first step is that a state actually has to decide that it will pay for language services in Medicaid and CHIP. Once it decides to do that, then the state would be eligible for that enhanced match that was enacted as part of the Children's Health Insurance Program Reauthorization Act earlier this year. And again, that enhanced match gives a state at least 75% of its costs reimbursed by the federal government for all CHIP enrollees and for kids in Medicaid. And as I mentioned earlier, we're really trying hard to get that extended to adults in Medicaid through health reform, and whether that is in the final package still remains to be seen. There's nothing in any of the bills that would require states to pay for language services in Medicaid and CHIP providers' offices. But since states are taking Medicaid and CHIP dollars themselves to administer the programs, they are subject to Title VI to provide language services in their own offices. So in terms of their own enrollment offices, outreach, activities, applications and forms, et cetera, the state does have an obligation to provide language services. What the state does not have to do unless it chooses to is help Medicaid and CHIP providers pay for language services. Those providers are subject to Title VI as well and therefore have to provide language services. It's just a question of where the funding to do so comes from.
Thank you. Okay, there are a few people on the call who are saying that they're a little new to the issue and they need a little bit of clarification on some of the terms that we're using. So they're talking about, can you explain a little bit more clearly about what language-appropriate services would be and what culturally appropriate services? Just, I guess, list some of the examples of some of those just to help some of the people who are new to the issue who are on the call.
Sure. In terms of language-appropriate services, it is critical that patients be able to effectively communicate with their providers. And if patients can't, it can impact outcomes, it can lead to medical errors, it can lead to a lack of understanding of treatment options and medication regimens and follow-up care, and it really can lead to a lot of difficulties both in terms of health outcomes but also possibly financial outcomes that if there is not effective communication and medical errors do occur, that healthcare providers might be subject to malpractice or negligence cases. So it is important both from a legal perspective but also, as we mentioned before, from the quality of care perspective that all patients be able to effectively communicate with their providers. And so that's where the provision of language services comes in. And this can be done through using clinicians who can provide services directly in non-English languages. It can be provided through using interpreters who assist with the oral communication between a provider and a patient, and also through translated materials. When we talk about translations, we're talking about the written communication, whereas interpreters are assisting with the oral communication. And there's other issues with regard to multilingual signage or use of symbols for wayfinding in hospitals or larger systems or facilities. A combination of those bilingual clinicians, interpreters, translators, generally is sort of how we define language services. It's also critical that the language services provided are competent. And there's recognition in the literature and also from the Office for Civil Rights and the Department of Justice that it is critical that language services not just be provided but be competent. And so the use of family members and friends, especially minor children, is something that should not be relied on knowledge of both English and a target language. There's a lack of knowledge of healthcare terminology, issues of confidentiality and HIPAA, and understanding the role of an interpreter. And being an interpreter is very different than being bilingual and able to speak in a different language or accept healthcare information in a different language. In addition, in terms of cultural competency, again, this is sort of a broad issue, but it's a recognition that people who are coming into the healthcare system come with different cultures, beliefs, backgrounds based on race, ethnicity, language, disability, lesbian, gay, bisexual, transgender status, socioeconomic status, education status, health literacy status. And it is important that providers recognize that one's background does affect their interactions with the healthcare system. And depending on the patient's background, they may have language needs, they may have communication or mobility needs, and there may be other issues that come into play on their religious, cultural, or spiritual beliefs. I think it's unrealistic to expect that a healthcare provider would become culturally competent in all cultures in order to provide care. And so I think some of the best practices is rather looking at sort of a self-reflection and training for healthcare providers to understand how culture can impact patient decision-making and patient outcomes, and that providers understand the need to have open conversations and dialogues with their patients about where the patient is and where the patient is when they come into healthcare and how that may affect treatment and outcomes. That might have been too long an answer. There's lots of stuff, lots of materials and resources on the web, and some really great information on cultural competency, on cultural sensitivity, on cultural humility, and information that's available. Some of it's on our website. There's also the well, I won't go into all of the list of resources, but I'm happy to provide some if folks would like offline.
Thank you, Mara. Okay, we have some more questions. If people still have time, it is 2 o'clock now, and we understand if some people need to excuse themselves, but we still have some questions coming in, so we're going to continue for a few more minutes. In reference to the nursing grant for ESL classes, is it to enhance English for all providers in their practice or in general?
No, the ESL classes, it's in a pipeline to nursing program, so trying to increase the number of folks who are getting into the nursing profession. And so one of the ways to help increase the pipeline is to increase the folks who may come in speaking other languages and need English as a second language classes to improve their English skills so that they could also become bilingual clinicians in the nursing pipeline. And so that's where the grant is. It's not for existing nurses to be taking classes in other languages.
Okay. Thank you for that. Can you speak about OCR and whether the vigilance has changed re Title VI enforcement with the new administration?
Sure. OCR is the Office for Civil Rights, and it's within the Department of Health and Human Services. And OCR is tasked with the enforcement of Title VI, as well as parts of the Americans with Disabilities Act, Section 504 of the Rehabilitation Act, and others. And so with the change of the administration, there is a new director of the Office for Civil Rights. And as of about a week ago, there's also a new Assistant Attorney General over at the Department of Justice in charge of civil rights. And folks actually may be familiar with his name. It's Thomas Perez, who actually was the head of the Office for Civil Rights at HHS during the last years of the Clinton administration. There has been some guidance put out by the Department of Justice about a renewed focus on enforcement of Title VI, and I think it remains to be seen as the new OCR administrator gets settled in what the priorities are going to be for that office, but we are looking forward to working with them and working with Thomas Perez over at DOJ as they move forward and develop this administration's policies and priorities.
Okay, we have a question about interpreter certification. and how will these reforms address the state's lack of certification process for healthcare interpreters in terms of providers' reimbursement?
In terms of Medicaid and CHIP, it is up to the state to determine if they are going to have any requirements regarding competency. And currently, 13 states plus the District of Columbia are providing payments for interpreters in Medicaid and CHIP. And their requirements regarding interpreter competency vary greatly. We actually wrote an issue brief on this for the Connecticut Health Foundation. Sorry, I just got a message, life intervenes, that my child at daycare is sick. I'll have my 15 minutes and have to head out the door. I'm sorry about that, but no, 15 minutes. Sorry, my daycare's on the phone trying to figure out what I can do, but that's why this ends in 15 minutes. Sorry about that. In terms of competency, we wrote an issue brief, as I said, for the Connecticut Health Foundation. It's available on their website, and that outlines, as of about a year or two ago, what the states did have regarding competency, and so that's a resource that folks can take a look at. Health reform does not address this issue. Issues of competency has generally been left to the states in Medicaid and CHIP, and with regard to Medicare, it's a study and a demonstration, and so it doesn't get into the issues, significant details with regard to competency.
Okay, since we are talking about health reform, there's a question that came up, and do your best to answer it, but it's a question that's on everybody's minds these days, which is, can you speak about the difference between a public option and local health consortia nonprofit health plans?
A lot of it depends on the details, and so it's very difficult to discuss true differences unless you really get into the weeds, because a lot of it depends on how a public option or how what they're calling a co-op is defined. And so that's really a difficult question to answer. In terms of the broad concepts, the idea of a public option is that there would be within the exchange as a choice for people who are purchasing their insurance through the exchange, a government-run option. And for most people, Medicare is the best example of a government-run option, although lots of people don't think Medicare is government-run. It actually is. But how a public option would work has really been discussed in myriad of ways, whether it would be an independent option, whether it would be subject to the same rules and restrictions of private plans, whether there would be funding, additional funding for startup for it. It really varies. And the same thing with what they call a co-op, which is, again, it's very much how it's defined. There are some co-ops that exist in practice, and those are generally seen as sort of a nonprofit health insurer. But again, how it's defined and what rules the co-op would be applied to the co-op, it's really hard to provide more details than that. So I can't make a recommendation, and I can't really provide information beyond that. I will say that there is information in the bills about it, and certainly there's different provisions regarding the public option in the Senate and the House. And I would refer folks to, I think it's, I'm not actually sure who has been focusing most on this. So I apologize, I can't provide more details on that.
I think you did a good job trying to address it, so thank you very much. Thank you, everyone, for participating. I think, should I try to do one more question? I guess we have a few more minutes. I'll try to do one more question here. What about integrating foreign-trained healthcare professionals into the healthcare workforce to promote CLAS? Is there anything, I guess, they just wanted your comment, if there's anything on any of the bills about any of that sort of initiative.
I have not looked that closely, so I can't say yes or no. And I don't want to draw any conclusions. I don't recall seeing anything, but it wasn't an issue that I was looking for, so I'm not 100% sure and would rather not speculate on based on what I was looking for.
Okay, that's fine. All right, we want to thank everybody for participating in this webinar and for going even longer than an hour. We wanted to try to see if we could address as many questions as possible. We would like to let you know that both sets of slides are available on the website already at diversityrxconference.org/yourvoice, as well as a list of follow-up resource materials that provide some additional information that will be useful to you. You'll also receive an email from GoToWebinar after this webinar that will give you a survey where you can rate your satisfaction with the webinar and then also give us some ideas for future webinars that we can hold in the future. And we apologized for, there was actually a little bit of technical difficulty, and Julia's not here right now, but she sends her apologies, and she thanks you all for participating. And if you have any questions, as always, please visit our website or send us an email at diversityrx2009@gmail.com.